بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, this is the start of the pediatric imaging series, and we will handle in this domain about 10 lectures concerning some of the neuro imaging and musculoskeletal imaging, spinal imaging, and gastrointestinal imaging as well. Then we will start by the neuroimaging, and we have in this domain about 3 or 4 lectures, starting by the normal brain anatomy by CT and MRI. Then we'll talk about hydrocephalus, then imaging of the pediatric brain tumors, then imaging of the cortical formation and the neuronal migration disorders, then imaging of pediatric CNS infections. And we may have time to discuss the white matter imaging, and let us start by this, and we'll talk after that about the topics I have mentioned. But first I would like to advise those who are not radiologists to listen for the lecture of the basics of MRI, which is included in the brain imaging series for adults first. And this will facilitate understanding some of the terms that I will use during these lectures, because there is no actually an adequate space to repeat these basics once more. So in order to understand what I am going to talk about, you should have this basics first. Then we'll continue. And you know that whenever we are going to examine a patient with CT or MRI, there may be some pre-examination preparations. And for the brain, by CT and MRI, we do not need any specific preparation apart from to make the patient fasting for about 3 to 4 hours. And this is only indicated whenever we intend to inject the patient with contrast material, or we are going to give him some sedation in order not to move on the machine, disturbing the examination quality. Then all the patients should have an examination of the brain before contrast injection. Then we look at the images, and we then decide whether this patient is going to be injected with intravenous contrast or not. And as a broad rule, we usually inject patients with contrast whenever we are suspecting an inflammatory pathology or a brain tumor. Then contrast is needed to discriminate between infection and the neoplasms, and also to differentiate between the types of infection and the types of neoplasms, as I will mention in details after that. Then to have a CT scan of the brain, we put the child on the CT machine, and we usually have this preliminary image, which is known as the scanogram. And the scanogram is obtained in the lateral view, and sometimes we can obtain a frontal scanogram, and this is usually done in whenever we are examining the chest or the abdomen, for example. But in the brain and the spine, we usually have a lateral scanogram. Then we say to the machine we would like to scan this area, starting from the base of the skull, ending by the vertex of the skull. And whenever you draw two lines for the machine on the scanogram, the machine will ask about the scan interval. What are the section leveling we would like to have? We usually have scan intervals at 7 millimeters for children and 5 millimeter for infants. But for adults, we usually scan at 10 millimeter scan interval. We try to align the start line at the famous orbitomeatal line, which is a line joining the lateral canthus of the orbit with the externodatory canal. And this will result in the good scanning for the brain, so that you are able to see the anatomic structures. I will show it to you. Then and you know the anatomy as well as the pathology if you tried to adjust this line at the orbitomeatal line. If not, we usually scan the skull from the base to the vertex according to the alignment we are able to obtain. Then after scanning, we will have these sections. The first at the skull base, and they will proceed superiorly until we reach the vertex of the skull. Then if we would like to scan the brain by MRI, we usually have what's known as the sagittal scout view. Then this is the sagittal. We start at the base of the skull. There is no angle here, no orbitomeatal line, but we start at the level of the foramen magnum and we proceed superiorly until we reach the vertex of the skull. Then the slice thickness is 5 millimeter, and we do not leave any interslice gap between the sections. For adults, we have the slice thickness at 5 millimeter, and we leave 2 millimeter interslice gap. Then if you have sections like this, starting from the base of the skull, proceeding towards the vertex, at some time you will cut the cerebellum and part of the occipital lobe posterior to it, and this will make some disturbances whenever reading the images of the MRI, because we feel that all the contents of the posterior fossa are just the cerebellum and the brainstem. But in cases of MRI, you should consider that some of the occipital lobe is located posterior to the cerebellum, because we do not have an angle to scan the brain. The MRI protocol should include sagittal T1, axial T1, axial T2, and axial flare, or the fluid attenuation pulse sequence. Then there is no coronal images in the regular protocol of the brain, but coronal images have specific values. I will explain this in details after that. Then I have mentioned that the regular protocol of the brain includes the axial T1, axial T2, and the axial the flare images. What is the value of the flare images? Let us look at this axial T2 of an adult brain with a lesion adjacent to the ventricle in this area. This lesion will appear in the T1 black, similar to the CSF, and in the T2 it will appear bright, similar to the CSF. But in the flare images, with the flare means that there is attenuation of the fluid signal, and it is a T2 weighted image where the CSF is black. Then the lesion is bright and the CSF is black. Then you have the chance for adequate visualization of this lesion compared to this T2 weighted image. Then if you look here and you see this is T1 weighted image, this is T2 weighted image, and this is FLAIR. In this patient we have two lesions in the brainstem. The lesions are infarcts. They appear of low signal in the T1, high signal in the T2. But because of the difference in the chronicity of these two infarcts we have in the FLAIR images, one is black and the other is bright. Then the infarction, which is chronic and is totally liquefied, it will behave like the CSF in the FLAIR images, so it will appear black. While the infarction, which is not yet liquefied, it will show some low signal in the T1 and high signal in the T2, and also high signal in the FLAIR images. So you should remember that in the FLAIR images, fluids which are similar to the CSF will appear black, while fluids which are not similar to the CSF will appear bright. And there is a good example here, and I will mention it once more, which is the difference between arachnoid cyst and epidermoid cyst. Arachnoid cyst contains CSF, it will appear black in the FLAIR images, while the epidermoid cyst contains fluid which is not similar to the CSF, so it will appear somewhat different from the appearance of the arachnoid cyst. Then, starting the anatomy of the brain, it is exactly similar to that in adults. And in the posterior fossa, in the basal sections, we have the fourth ventricle as our anatomic reference. This is a CT image, MRI T1 and MRI T2. And if you look to the sagittal image, and you can see that this is the fourth ventricle. Anterior to the fourth ventricle, the brainstem is present. Posterior to the fourth ventricle, you can see the cerebellum. The fourth ventricle is large at its middle part, and it is small below inferiorly and is small superiorly. When the fourth ventricle is large, then the largest part of the brainstem, which is the pons, is located in front of the fourth ventricle. When it is small from below, then the medulla oblongata is anterior to the fourth ventricle, while superiorly the midbrain is anterior to the fourth ventricle. Then if you have a section like this and the fourth ventricle is large, and you know that the pons is anterior to the fourth ventricle, then this is the pons and this is the cerebellum. In the cerebellum we have the left hemisphere, the right hemisphere, and the body of the cerebellum, which is known as the cerebellar vermis, which is exactly present in the midline. Anterior to the fourth ventricle you see the pons, and anterior to the pons you see the basilar artery, which is a famous artery located in the midline along the anterior aspect of the pons. Then you can see the prepontine cistern, which is the CSF space anterior to the pons and posterior to the cella, as you can see here. The junction between the pons and the cerebellum is known as the cerebellopontine junction, or the middle cerebellar peduncle. And you know that the cerebellum is connected to the brainstem by three peduncles: the inferior, the middle, and the superior. The middle is the largest one, which connects the cerebellar tissue by the pons. And you see this is the prepontine cistern. It has a small extension on the left side and another extension on the right side. This is known as the cerebellopontine angle cistern, or the ambient cistern. This is the left one and this is the right one. The same anatomy is seen in both MR images, and this is the fourth ventricle, left cerebellum, right cerebellum, cerebellar vermis, and this is the pons. And you can see the basal artery here, and you know that all arteries and the flowing blood in the MRI will appear black because of the signal void. Then you see this is the cerebellar vermis. Posterior to the cerebellum there is a CSF space here, which is known as the cisterna magna, and this is the appearance of the cisterna magna in the CT and the MRI T1 and the MRI T2 weighted images. And if you look carefully in the MR image, you can see this nerve, which is the trigeminal nerve coming from the brainstem into the cerebellopontine angle cistern, then going through the skull base to reach the paracellular area, as I will mention in details after that. Then if you look to the fourth ventricle, it is large. Then you go inferiorly, the fourth ventricle will be small. Then anterior to the fourth ventricle, whenever it is small, for in the lower sections, is the medulla oblongata. This is the medulla oblongata, left cerebellum, right cerebellum. And in the midline, you cannot see the vermis here, and you see a CSF space connecting the fourth ventricle by the cisterna magna, and this is known as the vallicula. And this is the vallicula, and this is the cisterna magna. Then after that, in the while you are going up, then you will see the vermis after that, and this is the vermis, and this is the site of the vermis. And here, this is the medulla oblongata, and this is the fourth ventricle. This is axial T2 weighted image, and this is axial T1. The fourth ventricle is sizable, and you can easily appreciate the trigeminal nerve. This is the pons, and this is the cerebellum on the left, the cerebellum on the right, and this is the cerebellar vermis. Then these are the three sections passing through the posterior fossa, cutting through the fourth ventricle whenever it is small, then large, then small once more. Then while you are going up, you will reach the level of the tentorial hiatus, and here you can see the end of the fourth ventricle whenever it is small, and you will meet one of the important cisterns in the brain, and this is the quadrigeminal cistern. The quadrigeminal cistern looks like a dish where the midbrain lies in its concavity, and this is the region of the midbrain, and this is the end of the fourth ventricle, and the same is here. This is the end of the fourth ventricle and the start of the midbrain, and this is part of the cerebellum, left cerebellum, right cerebellum, and in the midline you see the cerebellar vermis. In the lower sections you see the inferior vermis, but in the upper sections you see the superior vermis of the cerebellum. Then here, if you look carefully, then you see the quadrigeminal cistern, and this is the classic configuration of the midbrain. This is the midbrain, as you see, and this dot represents the aqueduct of Sylvius. You know that the aqueduct of Sylvius connects the end of the fourth ventricle by the third ventricle. Then this is the aqueduct of Sylvius, and this is the midbrain. And the anterior part of the midbrain here is known as the cerebral peduncle. And you have three cerebellar peduncles and one cerebral peduncle. This is the cerebral peduncle. Then this V-like CSF space is known as the interpeduncular cistern. This area is known as the interpeduncular cistern, and in this cistern you see two very small bodies adjacent to each other, and these are the mammillary bodies. These are the mammillary bodies. You can see them very well here, and this line represents the optic tract, and this also represents the optic tract. Then this is the interpeduncular cistern between the left and right cerebral peduncles. In the interpeduncular cistern you can see the mammillary bodies. Then one of the important issues here, especially in the pediatric age group, is to locate the site of the medial temporal structures, particularly the hippocampus and the amygdala. We have reached the tentorial hiatus, and this is the site of the midbrain, surrounded by the quadrigeminal cistern from posterior, the interpeduncular cistern from anterior, and finally this is the suprasellar cistern. Then the space the structure which is located between This is the temporal horn of the lateral ventricle. Between the temporal horn of the lateral ventricle and the midbrain, this area is the area of the medial part of the temporal lobe, containing the hippocampus anteriorly and the amygdala posteriorly. Then if you look carefully in this particular case, you see that the left temporal horn is very small, and this is the normal appearance, while the right temporal horn is distended, and that's because the hippocampus here is abnormal. And you can appreciate this if you look carefully here. This is the normal appearance of the hippocampus in the coronal image on the left side and on the right side. But in this example, which belongs to these two images, you can see this is the normal hippocampus on the left side, but the right one is of abnormal bright signal in this T2 weighted image, denoting the presence of mesial temporal sclerosis. I will explain this whenever we reach the pathology. What do we mean by mesial temporal sclerosis and how can we diagnose? Then this is the CT section, and you can see the quadrigeminal cistern, you can see the midbrain, and it's usually difficult to see the optic tracts and the mammillary bodies, but by MRI it's easy to see the mammillary bodies, and you can see the optic tracts as well, and you see the quadrigeminal cistern as well as the aqueduct of Sylvius. Then whenever you are going up, then we have finished with the fourth ventricle, and now we are approaching the region of the third ventricle. Then we are cutting here. These are the ventricular system, fourth ventricle, third ventricle, and two lateral ventricles. If you are cutting at this level is known as the basal ganglia level. In this level you can see the frontal horn of the lateral ventricle and the occipital horn of the lateral ventricle. In between you will see the third ventricle. This is CT image, axial T1, axial T2 MRI. Then you see this is the frontal horn of the ventricle, and this is the occipital horns of the ventricle, the frontal horn and the occipital horn. The third ventricle is this structure lying exactly in the midline. Then this is the frontal horn, and this is the occipital horn, and this is the third ventricle. And anteriorly you can see sometimes a foramen, which is the foramen of Monro, opening between the frontal horn of the lateral ventricle and the third ventricle. And these are the foramina, the sides of the foramina of Monro. Why this level is known as the basal ganglia level? Because you can see the basal ganglia structures, most of the basal ganglia here. In the concavity of the frontal horn of the lateral ventricle, you can see the head of the caudate nucleus, and in more laterally you can see the lentiform nucleus, which is like a triangular in shape. And on either side of the third ventricle you can see the thalamus. This is the left thalamus and this is the right one. Of course the delineation of these structures is a little bit difficult in the CT images, but in MRI, especially in the T1 and T2, you can see this is the head of the caudate nucleus, and this is the lentiform nucleus, and here is the site of the thalamus. Then the caudate nucleus is here, and you can imagine each site by CT, and the lentiform nucleus is here, and this is the site of the thalamus. Then where is the internal capsule? And the internal capsule is the structure which is passing through or in between these anatomic structures, the head of the caudate, the lentiform, and the thalamus. Where is the quadrigeminal cistern? This is the quadrigeminal cistern. In the lower section you can see the quadrigeminal cistern like the dish here, but in the higher section you see the quadrigeminal cistern rhomboid in shape. It has 4 corners, and this is the site of the quadrigeminal cistern. Then this corner is known as retrothalamic cistern because it lies posterior to the thalamus. And this one also is known as retrothalamic cistern because it lies posterior to the right thalamus. and this area is above the cerebellum, so it is known as the superior cerebellar cistern. Then the anterior corner is just a CSF recess passing above the third ventricle. It is known as the velum interpositum. I will talk about this velum interpositum later on. Then what is the choroidal fissure? It is the retrothalamic cistern. The retrothalamic cistern, and this part and this part, is sometimes known as the choroidal fissure in some of the radiology books. Then where is the hippocampal tail? It lies exactly posterior to the choroidal fissure. This is the area of the hippocampal tail, and this is the area of the hippocampal tail, and here. Oh, what is the hippocampal tail? It is the rest of the hippocampus. You know, the hippocampus is formed of a head, body, and tail. The head and the body are seen between the temporal horn of the ventricle and the brainstem, while the tail is seen superiorly posterior to the choroidal fissure. Then this is the internal capsule in the CT image, and if you look here, and if you are asked about this structure, you can say this is the caudate nucleus, and this structure, and you say that this is the lentiform nucleus, and here you can see the left thalamus, and in between these structures you can appreciate the internal capsule. Then if you go up, you are cutting in the body of the ventricle, and this is CT, MRI T1, MRI T2. And here is the body of the left lateral ventricle. In the right lateral ventricle, they are separated in the midline by the septum pellucidum. Then the head of the caudate nucleus is seen here. This is the head of the caudate nucleus. The body and the tail of the caudate nucleus are seen along the lateral wall of the ventricle, and this slightly faint hyperdensity represents the body and the tail of the caudate nucleus. Then the septum pellucidum is a fine septum separating the bodies of the ventricles, and the brain substance is divided into two parts: the white matter, which is a little bit dark in CT and MRI T2, and it is bright in MRI T1. And you can see also the cortex of the brain, or the gray matter, which is brighter in the CT and MRI T2 and dark in the MRI T1. And also you can see the interhemispheric fissure separating the two hemispheres. And you know that the white matter appears the opposite of its name in the CT and MRI T2 weighted images. The white matter will appear a little bit dark, as you can see here, and the cortex will appear the opposite of its name. The gray matter will appear somewhat bright in the CT and MRI T2 weighted image, but the white matter and the cortex will appear exactly similar to their names. In the MRI T1 weighted image, the white matter is white and the gray matter is gray. So it's frequently said that the MRI T1 weighted image is used for the anatomy, while MRI T2 weighted image is used for the pathology. Then in the supraventricular level, you can see the white matter and the cortex, and this is CT, MRI T1, and MRI T2. And you see the interhemispheric fissure, and also you can see the separation line between the gray and the white matter. This is known as the gray-white matter interface. Then if you are confronted in the CT brain by a lesion, and this lesion is located here, and you say this is left cerebellum, and here this is the vermis, and here this is the right cerebellum, and here then this is the bones, and here this is the middle cerebellar peduncle, but here this is the temporal lobe, and here this is the frontal lobe. Then if you are cutting at the level of the ventricles and you want to know the lobar anatomy, you draw two lines, one anterior to the ventricles and one posterior to the ventricles, like this. Then the brain tissue anterior to the first line is the frontal lobe, and the brain tissue posterior to the second line is the occipital lobe. Then this is the frontal lobe and this is the occipital lobe, and the area in between will represent the temporal if you are in the lower sections, and the parietal if you are in the higher sections. How can you know that you are in the lower sections or in the higher sections? By the detection of the third ventricle. If the third ventricle is seen, you are in the lower sections and this is temporal. If you don't see the third ventricle but you see the bodies of the lateral ventricles, you are in the higher sections and this is the parietal lobe. Then if you are higher up and there are no ventricles, just draw 3 lines dividing the section into 4 quarters. Then the first quarter belongs to the frontal lobe, while the remaining 3 quarters belong to the parietal lobe, because the occipital lobe is very small. It has been finished in the lower sections, and also the temporal lobe is no more present. But if you are very high up in the sections, you are left only with the parietal lobe in most of the cases. Then what are the values of the sagittal images? Actually, they are very important, especially in anatomic localization. In the sagittal image, it's easy to know that this is the frontal lobe, and this is the parietal lobe, and this is the occipital lobe, and this is the cerebellum, and this is the pons, this is the midbrain, and this is the medulla oblongata in a single section. And this is an easy way to identify exactly the site of the lesion. Number 2, delineation of the corpus callosum, which is the commissural fibers connecting both hemispheres. In the sagittal images, the corpus is well delineated by its 4 components. You know, the corpus has 4 components: the rostrum, the genu, the body, and the splenium. Then the craniocervical junction in this particular area, assessing abnormalities going from up down or from down up, and we'll discuss in details the Chiari malformations and many lesions that can be located at the foramen magnum. It is very easy to detect the superior and inferior extensions of these lesions in the sagittal images. Then evaluation of the venous sinuses for the possibility of venous sinus thrombosis. The sagittal images are important, particularly for the superior and inferior and the straight sinuses. Then evaluation of the pituitary gland. The pituitary gland is particularly evaluated in the coronal images, but in the sagittal images, before injecting contrast media, you can easily differentiate the posterior pituitary from the anterior pituitary. The posterior pituitary will be brighter than the anterior pituitary because of more triglyceride content of the posterior pituitary. Then if you inject contrast, both parts will enhance similarly. Then you cannot discriminate the posterior from the anterior. Then you know that MR images start from the sagittal images, start from the left and ending on the right side. Then this is the left image and this is the right image. So this is the left frontal lobe, left parietal lobe, left temporal lobe, left cerebellum. And if you reach the midline, you cannot know exactly which lobe is this one, the left or the right. But in this image, which is frequently shown in the exams, in ECG, if this part is annotated and you say that this is the frontal lobe and don't mention left or right, and this is the parietal lobe, this is the occipital lobe, and this is the cerebellum, midbrain, pons, and medulla oblongata. Actually, if you are cutting exactly in the midline, you will see CSF in the interhemispheric fissure, like this T2 sagittal image, and this area is exactly in the midline, and it shows CSF within the interhemispheric fissure. The coronal images are not routinely obtained in the regular brain scans, but the coronal images are particularly important whenever you are evaluating the pituitary gland, the optic chiasm, and the hypothalamic area. Also, the coronal images are very important for evaluation of the hippocampal formation. Also, you remember that I mentioned you can see the trigeminal nerves in the axial images, and also you can see the trigeminal nerve on both sides of the brainstem in the coronal images. And one of the ways to evaluate the vascular structures of the brain is the coronal T2 weighted image, and this is the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery. Finally, we came to the process of myelination, which is an important issue to understand. Myelin is a protein lipid complex, and this myelin is deposited in the white matter starting during the fetal life and continuing after birth for about 2 years of age, and by this age the complete myelination of the white matter is expected. And myelin, as I have mentioned, is a protein lipid complex, and it replaces water in the white matter. So the fetal brain contains, the white matter contains a lot of water, and before delivery the brain starts to deposit myelin instead of water in the white matter. Then if you know that water is black in the T1 and bright in the T2, while fat is the opposite. Fat is bright in the T1 and dark in the T2 weighted image. And these are some of the times for myelination, but you don't need actually to know them by heart, but we all have these charts beside our desks whenever writing a report for MRI of the brain, looking every now and then for if this myelination is good or not. Then the thalamus, it should be myelinated at birth, and whenever there is fat in the thalamus, which is this is myelin, and you see that the fat is bright in the T1, the opposite of the fluid. The posterior limb of the internal capsule by 1 month, the optic radiation by 3 months is, anterior limb of the internal capsule by 6 months is, and the parietal lobes by 8 months is. And this is a 6 months old child, and you see this is T1 and this is T2. Myelin will appear bright in the T1 and dark in the T2 weighted images, and these areas are myelinated, and also these areas in the internal capsule, you remember, in the region of the thalamus, and some of the white matter in the occipital lobe and in the parietal lobes, these are myelinated. They are bright in the T1 and the dark in the T2 weighted image. But the brain of a newborn or an infant, it will be loaded by water, and the white matter will be black in the T1 and bright in the T2 weighted images. And this is the normal appearance of an infant brain 3 years old. The white matter is full of water. Water is black in the CT and also black in the MRI T1 weighted image, but will appear bright in MRI T2 weighted images. And this is a 7 days old infant with CT image showing the normal appearance of the white matter, which is black in the compared to the cortex of the brain. And this is 17 days old infant, and in the T1 weighted images the white matter is black. In the T2 weighted images the white matter is bright. Then this is an 8 days old male, T1 and T2 weighted MR images. The white matter is dark here and is bright here. Then by the age of 10 months, the patient, the child is approaching the normal values for an adult. Then here you can see the myelination of the brainstem and the myelination of the internal capsule, the thalami, and some of the white matter in this T2 weighted image, and in the T1 the white matter will appear bright. Then by this age the brain should be exactly similar to that of the adult brain. By the age of 2 years you see complete myelination of the white matter, which is dark, and it will appear bright in the T1 weighted image. And sometimes in the brain of a child 2 years old, and you can see that the white matter is dark. This is normal, but you see inside the white matter some patches of bright signal, and this should be regarded or should be considered as areas of delayed myelination. And you should not go or jump for the diagnosis of leukodystrophy or demyelinating processes until this is or unless this is supported by the clinical and the laboratory findings. And there are two normal variants in the brain of the child. The first one is the cavum septum pellucidum. And you know, the septum pellucidum is a membrane separating the two ventricles. This membrane may have a cavity, and this cavity collects CSF inside, and this is usually referred to as the fifth ventricle, because you know we have 4 ventricles, and this is a chamber containing CSF. It can be considered as a ventricle, which is known as cavum septum pellucidum if it is located only between the frontal horns of the ventricle. If it continues between the bodies of the lateral ventricles, you call it cavum septum verge. Then this is cavum septum pellucidum and verge. And this is cavum septum pellucidum, MRI T1, MRI T2 weighted images, and you see that the septum is containing CSF. You need to remember that the quadrigeminal cistern have four corners: the retrothalamic on the left, the retrothalamic on the right, and the superior cerebellar on the back, and the velum interpositum anteriorly above the third ventricle. This velum interpositum may enlarge and contain CSF, and at that time we call it cavum velum interpositum or cavum interpositi. And this is also a normal variant where you can see a collection of CSF in the anterior part of the quadrigeminal cistern. And thank you very much. Walhamdulillahi Rabbil Alameen.